Thank you, ma'am. Thanks for the introduction. First of all, good evening, everyone. So grateful, and I thank Professor Mohan sir, Anjana ma'am, Ranjit sir, and the team for giving this opportunity. I know I'm conscious of the time, and I'm also talking to learned audience. So I'll straight away get into the topic. So we all agree that just now as I'm speaking, there are thousands of people all over the world who are experiencing hypoglycemia. So at homes, at clinics, being treated in hospitals. So as physicians, diabetologists, endocrinologists, it's even for anyone, okay, I would say knowing how to treat hypoglycemia and knowing a bit about hypoglycemia is extremely important. Both ADA, EASD agree that any level less than 70 milligram per deciliter is the number we're looking for. So anything less actually is hypoglycemia. Why is it so important? Even few minutes of lack of glucose to the brain actually can cause permanent damage to the brain. So that's why it's very important. And as you see in the slide there, body tightly regulates glucose. The liver is increasing sugar and the pancreas is bringing down the sugar by releasing insulin. There is always a tight regulation unless until you tamper with the balance of it by using drugs or other things. Usually it is very unusual for a normal person to experience hypoglycemia. So there are many people who come into the OPDs and say, doctor, probably I had low sugar. So how do you know whether they had low sugar? So Whipple's diet helps. So always document, it should be less than 70. They should have signs and symptoms of hypoglycemia. And when you give glucose, they should improve. So this is Whipple's diet. And extremely important, especially if you're evaluating for hypoglycemia in those who don't have diabetes. So I'm brushing through the slides so that I'll only focus on important things. So we all know about the symptoms, autonomic symptoms, all this sweating, tingling, trembling, and all of these symptoms. And then then follows the neuroglycopenic symptoms, which are very dangerous, and confusion, dizziness, and difficulty in speaking, and feeling faint. So if you look at how, as the sugar drops, okay, the first thing that happens is the insulin is shut off, right? And then comes the glucagon, then comes the catecholamines, and then comes the cortisol. So this is the sequence of events that happen, the hormonal responses the body produces to actually to tackle the hypoglycemia. So that's another slide for you. So if you look at the classification based on the severity, level 1 hypoglycemia is anything less than 70 to 54, level 2 is less than 54, and level 3 is any severe thing that will actually require assistance. There's another one, mild hypoglycemia, moderate hypoglycemia, and severe hypoglycemia, just based on the kind of symptoms the patient experiences. Now, as we all know, diabetics routinely come with hypoglycemia, right? So it could be sulfonylurea, it could be the insulin mismatch, they delayed the meals, skipped the meals, and all of these are very common in our day-to-day practices. And gastroparesis, again, can sometimes cause unpredictable glucose absorption, and there can be hormonal deficiencies. So this is a long list of, for who are capturing it, yes, you can, but I'm not going here because it's a very, it's beyond the scope of the talk. But understand that people who don't have diabetes can also develop hypoglycemia, and they need a very systematic evaluation and to find out the root cause. Few reasons I would say. Insulinoma is a popular one. Most people know about insulinoma. There is something called autoimmune hypoglycemia, and very common are people in ICUs with critical conditions like sepsis and organ failures and even hormonal deficiencies. So always before you treat hypoglycemia, always understand there can be a factitious hypoglycemia. People are probably deliberately taking insulin or sulfonylureas. Rule out lab errors. And also there is an entity called relative hypoglycemia. Patients come with symptoms of hypoglycemia. The sugar is actually not very low, but they tend to get all the symptoms of hypoglycemia. This is called as relative hypoglycemia. Now, just to point about pharmacological, so we just heard a talk about drug-induced diabetes, but there are also many drugs that can actually cause hypoglycemia. Now with the advent of pens, most of this, this confusion is going away, but I think even still, there is this insulin unit 40 and 100 confusion. So people, if you take, let's say you have a 40 unit syringe, 40 IU syringe, and you're taking 100 IU insulin in the 40 unit syringe, you're going to overdose. So always take the 40 IU with the 40 syringe and 100 with the 100. So alcohol, very common. It inhibits hepatic gluconeogenesis and it can actually produce post-hypoglycemia. Just yesterday, I had a patient who was put on propranolol 40 mg BD. He had hyperthyroidism by an endocrinologist, and this guy was actually knocking off. It was around 30. The son came very anxious and said, "Doc, I'm getting 30," and No, I was just asking him, why is he not getting symptoms? Because the autonomic symptoms are completely numbed because he was on a non-selective beta blocker. So understand that propranolol or beta blockers can actually cause problems. So we looked at the drugs again, and then sulfonylurea, a small word, is this. The SU hypoglycemia can be prolonged, so just don't treat and then send them home. So sometimes many of these might need admission. So a word on nocturnal hypoglycemia. We know that it's very, very common now with the advent of basals and a lot of newer regimens where nocturnal hypoglycemia is going down. But you see the dawn phenomenon where you can see the normal blood glucose at bedtime, normal in the middle of the night, and the high in the morning. So that's because of your hormones. The opposite is the soma effect, where there is a low sugar in the middle of the night and then they have a high in the morning. So don't always increase insulin doses considering just the fasting being high. So hypoglycemic unawareness again is very common in type 1 patients where repeated hypoglycemias actually can numb, I would say they will not be able to sense hypoglycemia, and CGMs are very helpful. So you have to relax the targets, keep them on higher targets for a few weeks, and mostly they will settle. So just a word on hypoglycemia without diabetes. I'm not going to talk on this. Okay. So if a person comes to you, he says that I'm not having diabetes, but I'm getting hypoglycemia. Always document Whipple's triad. And then look whether it's fasting hypoglycemia or a postprandial hypoglycemia. Generally, fasting hypoglycemia is any hypoglycemia that occurs more than 5 hours after a meal. And if it is happening less than 5 hours before a meal, then it's postprandial hypoglycemia. So most commonly, insulinoma is a fasting hypoglycemia. So small keys in insulinoma is that no role for USG, no role for your CTs. The best thing that is available is endoscopic ultrasound, and the best PET scan that is available is gallium-68 extended PET. If you can get it, this is very specific for insulinoma. So when you're looking at postprandial hypoglycemia, there are only two things. I'm sorry for people who are taking the pictures in the interest of time. I'll just give you an overview about postprandial hypoglycemia. So there is something called as elementary hypoglycemia, where in patients who had bariatric surgeries, you can see that there is a large spike, and then followed by of sugar, followed by a very spike of insulin, leading to hypoglycemia. But the same thing in patients with early diabetes. If you see, the problem is not the huge spike of insulin, but it's usually there is a delay in the first phase, or there is a loss of the first phase, actually leading to late hypoglycemia. The second phase of insulin secretion compensates for this. So let's give you I'll give you a overview on how to treat hypoglycemia. So I still remember there was long back, 5 years back, there was one, they called me to a home. And then, sir, doctor, in my apartment. And the guy was actually unconscious. Then I checked the sugar, it was hypoglycemic. And frankly, I didn't know how to treat him because I was thinking, okay, what if I give sugar? Then later what I did was, I read somewhere, the buccal mucosa is where you need to actually, so this is a very common scenario. You're not given access to glucagon, DNS, nothing, okay? So all of this will only come when your ambulance services come. So probably apply sugar, a little bit of honey inside the cheek, and that can probably help. So clinical pulse. So number one, always check glucose in those who are altered mental status. So always check. The second thing is know your thresholds. So less than 70, but most people experience symptoms when they're less than 50. So Whipple's triad is key because in our OPDs, we see a lot of people, anxious patients coming, doctor, probably my sugar is going low. I'm having palpitations, I'm having sweating. So always document Whipple's triad. So especially if the patient is non-diabetic, don't do expensive tests without actually establishing Whipple's triad. So then look at, is this because of insulin or is it because of any other problem? Like for example, malnutrition can cause, alcohol can cause, and adrenal insufficiency can cause. For postprandial hypoglycemia, the test of choice is extended GTT or a mixed meal test. So avoid iatrogenic hypoglycemia. So always use basal insulin, probably prefer SGLT inhibitors or DPP-4 inhibitors, and try to, especially in elderly and vulnerable population, reduce your sulfonylureas. And in people with hypoglycemic unawareness, always relax the target, okay? Because at least for a couple of weeks or a month, you have to relax the target. And I told you about how to treat hypoglycemia. Always exclude drug-induced, lab errors, exercise-induced, and factitious hypos. Thank you so much for your patient listening here.